think we are done. We'll move on to the panel discussion on EGFR-mutated lung cancers for the past 2 sessions. I would like to invite our moderator, Dr. Ullas Batra, who's a senior medical oncologist from Rajiv Gandhi Cancer Center, Delhi. And our panelists, Dr. Prahlad Delamarti, Dr. Manoj Mahajan, Dr. Roshni Pandey is, I think, not here, Dr. Pradeep Ventrapati, Dr. Pritesh Munot, and Dr. T.P. Sahu.
I think somebody's earpod is remaining.
So I think Ullas has not been introduced properly. He is one of the finest lung cancer oncologists in the country.
I am going to get... anyway, sir, 11 abstracts in 30 minutes is a kind of a too much even for Dr. Sahu and us all combined together. But I thought I'll do initial analysis and we will try to do everything in one. But I think I have just divided my moderation into 2 lines, the first line, the second line, and then some real world practical scenarios. So when we talk about EGFR mutant non-small cell lung cancer, trust me that last 2 years back, I mean, the discussion would have been boring. I mean, all that you discuss is the NK regimen and you discuss Osimertinib and which one will you actually give. But from the last 2023, 2024, especially since the last ESMO and the WCLC, EGFR is absolutely fantastic, and now we have so many presentations which are there, it's going to be very nice and fun to treat EGFR mutant non-small cell lung cancer. So I'll start with this side, Dr. Manoj. Your choice of treatment of first line EGFR mutant non-small cell lung cancer, and Vanita is in the house.
So you are advising me one bias?
No, I'm just telling you that. I still don't give Jeffrey and I still don't give that regimen. I'm telling you on record here.
Yes. Sir, if the financial toxicity is not concerned, then we go with the OC. But most of the times it is a concern. So standard is either we combine JEF plus PEM, or if patient desire to go for a single agent.
Dr. Sahu is going to go to Goa next one. Dr. Sahu, it is not yet time for Goa. You cannot, Dr. Sahu's eyes lit up like this. I wanted to, that is why I purposely look at this. I hope there's a video of here which I can show you to your wife, Dr. Sahu. It is just because I just got late and this was the only picture which was available. It's okay, stop smiling now, Dr. Sahu. Okay. Pradeep.
Osimertinib, sir.
Osimertinib, yes.
Osimertinib, if not affordable, PEM Carbojef.
Okay, Osimertinib, otherwise the NK regimen.
So I think it cannot be a straight answer.
Dr. Sahu, don't look at the picture over there. Okay. Just look at let's look up and then talk.
Okay, I think it's not going to be a very straight answer. The type of mutation, the bulk of disease, and the financial all put together will be
around 100 patients of lung cancer EGFR mutated.
So if I don't have a brain mets, it will change. So if let's say I don't have a brain mets, I probably will go for a third gen TKI. Finances is not an issue. Okay. But if I have a brain mets, it will change totally. If finances is the issue, reality, the Jeftinib Pemetrexed protocol does come in.
Fantastic.
The take home should be that if you use a first generation, it should not be alone. It should be with something else.
Okay,
that's
fantastic.
What it should.
TKI plus something. Fantastic.
If affordable, third generation TKI Osimertinib. If not, NK regimen.
Okay. Nandini?
So like Sahu sir said, taken to multiple factors, whether there are any co-mutations, volume of disease, brain mets. So if in an ideal scenario, if the patient is very fit and some adverse co-mutations are there and a large volume disease, maybe Osimertinib chemo. If the patient has lower volume disease, maybe not as fit Osimertinib, and a lot of patients who have uncommon mutation cannot afford Osimertinib, still have large volume, do well with Jeftinib chemotherapy. So we commonly use Jeftinib chemotherapy.
The NK regimen.
But we also use now Osimertinib chemo in certain patients.
Apart from the co-mutations, even 1921 differentiation.
Okay, we will come to that. So we'll start with the first one. The OS update of the NK regimen, and for people who are, I'm just trying to embarrass Vanita more. The NK regimen is just been coined by me, the term, that is the Naronoha Kumar kind of a regimen. It's an opposite of KN regimen. And this was a research letter which was published in JAMA, I think. And congrats, Vanita. And this was 2023. But this is one of the more defining moments of my journey as a medical professional. To seeing you up there on the podium at 2018, 2019 was fantastic. Yeah, but I didn't get any Google snap of that. So that is why I put 2023. But that's it. So this was a 5-year survival update where we basically got 27.6 versus 17 months median OS. So we will start with Dr. Sahu. Does it really work as well in the, I mean, you know, now that I've said congratulations, put a snap, let's get to real stuff. Does it work as well, and what are the toxicity that you have seen?
It works, that's for sure, but because
As
the
well?
comparator, see, if you're comparing with Osimertinib, then it's a different ballgame. You're comparing with the Gefitinib, addition of it works, that's for sure. I don't have an experience of 50, I maybe have 15, 20 patients. So on that experience, I can tell you, yes, it is toxic, more than what you would expect from a single agent. You would not be using it for 75 years old lady who walks in. So it is toxic, and the first 2-3 cycles is something, first 2 cycles, something which I'm very careful. But it works, and the good thing about it is, as I told you, even if you have brain mets and their data showed, and even if you look at Chinese data and the Japanese, also with that regimen, it works better than Gefitinib.
In the, Vanita, I think, but in the patient who had brain mets, a lot of people had taken
They
whole brain
are taken
artiplier.
radiotherapy.
They had
They are
taken
taken
a whole
radiotherapy.
brain
They are taken
artiplier.
radiotherapy.
Fantastic.
Agree.
So it does work, but my concern, even with FLORA2 and the NK regimen, has been the kidney toxicity. I mean, somewhere down the 8 and 10 cycles, I mean, initially we didn't know. I mean, now that even with you go for the keynote 189 also, you find out after 12, 13 cycles, you actually have to stop pemetrexate for some part or another. So that is obviously there. A low incidence of T790M, Manoj, I mean, they just showed 17%, this, I read yesterday evening, मुझे मालूम था आप आ जाओगे यहाँ पे. 17% rate of T790M. Did you read? You were an author. You were author of that. Okay. 17% rate of that. Is it because FLORA2 we saw there was not much of change in the resistance mechanism. So what could be the explanation for that?
I'm really not sure.
We are not really sure. So let's ask Dr. Vanita only. Dr. Vanita, I mean, do you think we didn't test much? Do you think what happened actually over there? It's okay, you're loud enough.
So 17% was from the original paper. With
Okay.
that, and that at that time that was a very early analysis. So lot of patients had not progressed, etc. So
Okay.
we are Dr. Shiva, my student, is actually going to be
Analyzing the
publishing. No, already analyzed. Going to be publishing the resistance mechanisms. There is a definite difference in T790M emergence between the two arms.
Okay.
Far more in Gefitinib than Gefitinib plus chemotherapy.
Okay.
Exact number I don't remember. I think it's like some maybe 20. It's not what is described
Not
in the
40,
literature. Not as
45%.
it's like maybe in the 30 to 25, 30 range.
It also depends upon the kind of testing that was
Yes.
used. Actually, if you
Absolutely.
use a DDPCR, you will get much more. If you use a normal COBAS, you will not get that. Right?
Absolutely.
So,
So,
I
the
mean,
majority were tested with RT-PCR. So not NGS
Correct.
testing
Correct.
at progression.
So, I mean, again, for the residents here, you know, it is very easy to say T790M, but see whether it was done on tissue biopsy, see it was done on liquid biopsy. If you do on DDPCR, which is not yet available because the reagents during COVID actually got finished and the companies are not really promoting that, it actually, it's a very sensitive technique, so it will pick up actually more. So just saying liquid biopsy or NGS or which technique is very, very important on that. Any data about Nandini, about L858R del19 co-mutations, or there was no data, I guess. I mean, at least not what is reported in this, but still. Dr. Pritesh, what if patient is affordable and Osimertinib is available? Will you go for this or you will go for Osimertinib? Go for Osimertinib. Fantastic. So, now the next question over here is to you, Pradeep, is do you think in 2024 a treatment with a single generation, even third generation DKI, is it good enough or is it not good enough for some or most of the EGFR mutant patients? I mean, do you think Osimertinib was a gold standard before 2023, you know? I mean, before the FLORA2 and Mariposa, everything came. But do you think it is good enough or you would want to add OC plus something in some of the patients?
I still feel it is good enough, sir. Not only in terms of efficacy, more in terms of the quality of life of the patient.
Quality of life of the patient. You are a strong believer of the
Yes.
Singaporean study, which we will come to later. Yes, your take.
Especially if the patient doesn't have a TP50 mutation or some other extensive liver, extensive
So
metastatic
what
disease.
proportion of your patients you would be happy, I mean just a hypothetical situation, happy in giving a OC plus combination? Let's say money is not an issue right now.
Only fit young patients, I would try.
Approximately.
Around less than 10%.
Less than 10%. Fantastic. Yes.
Sir, as there are multiple factors, as Dr. Sahu was pointing out. For the higher volume of disease, probably I'll say it's not good enough. Fit patient, very minimal disease, OC alone would be a good enough.
Out of the last 100,
Yes.
out of the last 100 patients that
I'll
Kumar
say
would
less
have
than
seen in the
10%.
last, he's gone out. Okay, in the last one day, how many? Okay, anybody? What is the thing of Flora 2? How many people have you given, Dr. Sahu?
Flora 2, no, none.
Flora 2, no, none. Why?
बड़ी
बड़ी बातों पे हम यहाँ आके करते हैं।
I don't have patient who can afford Osimertinib.
So
You send
let's
me,
say-
I'll give it.
If I have a patient, I'll only give it.
No,
Why should I send it to
seriously
you?
now, seriously now, taking it forward, who would be looking? You would be looking beyond Osimertinib.
Okay.
If I have to look into it.
So how do you decide?
Yeah. So I feel the brain mets is one point which I'll be very seriously looking into. They are anyway going to do poorer, but the hazards looks much better from the brain mets when you add a chemo. The TP53, I'm no more that convinced with the exploratory analysis data. We may criticize exploratory data, but the response rate, if you look at the publication, it's only 5% more. It's not a huge jump in the response rate. Osimertinib anyway is doing so great.
Okay.
So I think the brain mets, 40% is a patient of brain mets which you have in Flora.
Okay. Liver mets, Dr. Vanita?
No, I just wanted to ask about the brain mets. I totally agree with you, and I have also tried it. Whatever I've seen is the patients who have those brain mets usually are the little bit poorer PS patients. So I'm not able to. So I agree. I've been trying. I've maybe ekad bar I have given it, but otherwise they are not.
What we do, Dr. Vanita, is we do MRI brain for everyone. And actually the data which we have is 38% of people have got some brain mets at diagnosis, and not the big brain mets. 20% of them will have small asymptomatic, and we have been able to give that for everyone. So just for the residents, how do you decide to which give OC or OC plus something? Look at the clinical factors, presence of liver, brain, young age, high volume of disease, or you look at the genomic factors, that is the LH58R co-mutation, and ctDNA is something which I am going to come. We'll talk about in the afternoon session also. So the options that you have, in the interest of time, I'll only tell you 4 options. You can add chemotherapy, you can add amivantamab, you can add the favorite ramucirumab also, and you can add North Star, radiation oncology also, you can add something over there. And let's do the cardinal sin of medical oncology. Let us just compare Mariposa versus, kind of a Flora 2. And what it basically does is that, there is a slight increase. HR is 0.62 for Flora 2. It is 0.70 for amylase plus chemo. So that is there. Nandini, do you think there is too much to differentiate between this, or how you decide between? So one is, let's say your fit patient has asymptomatic brain met, has a TP53 mutation. Now, how do you decide? Mariposa or Flora 2? And money is not an issue.
It's a difficult decision to make because they are not being head-to-head compared. But the Flora 2 has...
You're Tata, you're supposed to tell. We've come here to learn.
Sir, Flora...
हम तो तुम्हारे पास भेज देंगे, वहाँ जाके ले आओ जाके वहाँ पे.
Flora.
Second opinion. And dare you people say कि वहाँ जाके उनसे जाके पूछ लो. I sent somebody for a second opinion, they said उन्हीं से पूछ लो. ऐसा थोड़ा होता है. Just say yes to whatever we say. Okay, tell me.
So the only thing is,
yes, please go ahead.
although, sir, I would prefer to use Flora 2.
Flora 2.
The only concern with Mariposa, though the data is good, there's so much of amivantamab-related toxicity in
So much of
patients.
toxicity.
Maybe it's probably individual experience, but the chemotherapy TKI toxicities are better managed.
Because we have been experienced that from the last so many years. So that is probably the reason. Is it, yes, Akhil, you had a point, and then Akhil.
So actually the point was brought out. The toxicity of amivantamab management requires another understanding, another art. So it's a different art which we will learn over time, and the problem will be solved to some extent when the subcutaneous.
The subcute one comes. Yes, Dr. Manoj.
Even I feel the combination like TKI plus chemo combination needs some drug dosage management to optimize maintain or optimize the efficacy. Because we are dealing with the toxicity in both the situations, OC plus chemo or JEF plus chemo. So we need some dose fine adjustment, probably generating data from the real world setting.
Okay.
Although there is no comparison all told, but still, if I have a co-mutation, a MET, I know which agent I'll choose for. That's one point.
You will choose?
I'll go for the amivantamab. Waste protocol. So second, if I have a TP53 with that exploratory analysis, I will choose a Mariposa rather than the Flora 2.
So I will like to take Dr. Sahu has said, what exactly was there. So I just told you about the clinical factors. I will show you some graphs. If you have brain mets, let's do another grave cardinal sin. Now let us compare subset analysis of a cross-trial comparison. When first we did a cardinal sin, then let's do a more. So first Dr. Sahu is smiling over here, after this is going to Goa. That's a more cardinal sin on his reunion party. So, have a video of that and see what is happening around. Okay, so let's compare a subset analysis of these two, and something which we should not do. Let us be very honest about it. In which FLAURA2 is slightly better than Mariposa. Both in L858R and TP53 mutation, Mariposa and FLAURA2 helps, although there was no formal comparison of in the FLAURA2 about the TP50. Numerically, it was better. In the liver mets also and baseline ctDNA also, Mariposa was slightly better. So my question over here to start with to you, Dr. Pritesh, would be, do you think, we are reading too much into this data? Are we actually torturing the data? Or you will decide it on the basis of a clinical. So let's say, if you have a brain mets, you will give FLAURA2. If you have a ctDNA positivity, you will give AMI, LAS and chemo. Or we are reading too much into this data. You will just decide, I'll give OC plus something, by and large they are same.
So there'll be two things. Number one, I'll give both the options to patients.
Correct.
Of course.
Patient says, Doctor, aap Bhagwan ho.
No, when there are multiple, say for example, as already mentioned, multiple high risk features, whether to use OC plus chemo versus Mariposa, I'll just explain that these are the side effects. At the end of the day, you have to choose, but I'll be more comfortable with OC plus chemo personally because we are more used to manage those toxicities.
Fantastic, toxicity. Nandini?
So we may be torturing the data, but right now this is all we have to make decisions. So until there is more randomized data, probably we'll have to make.
So you will say if somebody's ctDNA doesn't clear off in 2 months or it is positive, you will want to go for amylase. Somebody with a liver met because the data is more, you will want to go for amylase. Somebody with brain, you will go for this. Is this the way, or you will say something and then we'll decide upon our own toxicity, the broad view?
So I think consider the data and then ultimately decide on patient fitness and toxicity.
Okay.
I think this is all exploratory. I think we should be taking the MET is one which I think will be one of the guiding. Otherwise, for brain mets, even the amiventa lazertinib combination looks good. Because lazertinib per se is a very strong.
Also, with the amivantamab chemo, they showed good CNS.
Good CNS. So I think we are reading too much into this. We go to all these ad boards and company people come and tell us we are reading too much into this. I think the basic thing would be to say whether we want to give OC or OC plus something. After OC plus something, it is your decision whether you want to go for the chemotoxicity or you want to go for the skin and the anticoagulant toxicity. Yes, Akhil.
Yes. So if we see wherever the data is coming positive, it is because of the number of patients in that subgroup.
Yes.
If it is smaller in
Correct.
OC plus chemo 65, that is why it is not. So I don't think that makes much more sense to
we are torturing the data a bit too much with this. So I don't think we should decide about whether you want to give single agent or combo, and in combo we decide on later over there. Safety, very, very important. We all know it's mostly the hematological and the nephrotoxicity which will be there in the FLAURA2. Dermatological, infusion related, and VT. Very, very important is whenever you're giving ME-LAS, please start them with DOACs to start with over there. So pros and cons, I think we know of both the regimens. The toxicity is basically a concern. My take on whether to decide between FLAURA2 and Mariposa is apna dekh lo. Jo jisko theek lage wo de do. As long as you decide about which one to give first, there is no one choice. I will go to both. I will promote both these things, but I think there is nothing really to choose between the two. So, on Monday morning, Dr. Pradeep, will you ask a broad-based NGS panel, including MET amplification co-mutation for your patients at diagnosis?
Yes, sir.
You will ask, yes. Okay. Dr. Manoj, will you ask for MRI brain and consider giving TKIs plus something for majority of your patients?
MRI brain, we like in locally advanced, or we do commonly.
You
for
look.
routine protocol.
Okay, in all these you will do commonly.
Yes.
Fantastic. And will you want to do give TKI plus something? Will the proportion increase?
If asymptomatic, then we can manage it.
Okay. Or Dr. Sahu, what stays in happens. What happens in Vegas stays in Vegas. Or what happens in YIR stays in YIR. And what happens in Goa stays in Goa. Will you change your practice or you will not change your practice?
So, which practice?
Your practice. How is already in Goa mood?
No, my point is we already see we have to do MR and flora too.
The MET amplification.
The MET amplification, I think it makes sense with the drug which is already there as a bispecific. The MR brain should be now done. The flora 2 just data set you look into. Kya hua? Okay. So if you look at it, you see that 20% in flora comes to 40% flora 2. So you are catching nearly double the brain mets, although most are asymptomatic.
Yes. Dr. Vanita?
I think ये सब ठीक है. I really want to know what is happening in Goa and can we also come along? क्या है?
So what is happening in Goa, we will never know, and you can never come along over there, please, because what happens in Goa stays in Goa. So for me, definitely a NGS panel, we will definitely ask for MET amplification by fish also, which a normal panel doesn't really cover. Considering MRI brain, definitely, I will not, we have been trying to get a flora 2 regimen for a lot of people, but over a period of time, I think not more than 10% of people or 15% of people actually are willing for a chemo plus OC combination, because, first you do an NGS test, you tell them what is the advantage of NGS test, that, you can avoid chemo. Then when the NGS report comes, you said you want to give chemo. So it becomes difficult. I think the way we have to counsel them.
Just keep the slide out of the context. Huh?
Yeah,
just feel that a person has read 2 nights telling the same answer. I have not read anything in a Goa mode. So randomized trial. So don't read much.
No. Okay. So this one was basically, this is very, very important for me. This was a trial which was a de-escalation. We did for intensification of therapy. Now let's do for de-intensification of therapy. With this, Doctor, I think I'll go to you, Pritesh. Can you cure a bioaddicted non-small cell lung cancer stage 4? Because this is what they're trying to do. They're trying to stop therapy over there. Are you a believer of consolidation RT? This is something which is practically very, very important. Are the current molecular assays sensitive enough in guiding treatment decision, and does re-challenge work in biomarker in non-small cell? This for me, this paper and the PEM carbo paper was very nice. So your take on this?
So cure, no.
Cure, no.
Believer of consolidation RT.
Sir, good morning, sir. Dr. Madmani, sir, good morning.
Believer of consolidation RT in metastatic, no, sir. Sensitive enough in guiding treatment decisions, yes. And re-challenge work, I've not had the experience with that.
Nandini, your take on this?
So cure, I wouldn't say no, because CML also was like no in the past, and now we are going for TFR. So we don't know cure or not.
So we don't know.
Yeah.
Okay.
So probable cure may happen if techniques of, I'm sure the assays are sensitive enough now, but we may have more sensitive assays in the future, and the concept of MRD may also come into play, which is so much of data which we discussed yesterday also. Consolidation RT, in our center we have a trial ongoing to look at it. So in certain patients who do well, they are looking at, and now there is upcoming data for even in EGFR whether consolidation RT may or may not help. But right now there are mixed results with the NRG LU002 showing no benefit versus benefit. So I think still evolving data.
Evolving field.
And re-challenge in biomarker, if there is a mechanistic resistance mechanism, it may not work. But if we stop because of some other reason like toxicity, then maybe re-challenge.
Okay. Dr. Sahu?
Mostly agree with all the things except for the consolidation RT in oligometastatic setting.
Because you read it yesterday.
Or a induced oligometastatic, it really, especially in the EGFR setting, really the data is encouraging.
Okay. So my take on this is, can you cure a biomarker related? Long-term control, yes. Cure, I am not so sure. You will have to give something over there. Believer of consolidation RT, we do. But please remember, a consolidation or a oligometastatic protocol is going to turn a good disease into a better disease. It is not going to turn a poor disease into a good disease. So that's the difference. Somebody is doing well, you absolutely make it better, but not a poor disease into a better disease. Are the current molecular assays good enough? I don't think so. I think we need much more assays over there. Does the re-challenge work in biomarker related? It is reasonably well. You stop for some time if there's no resistance, but we need more studies on that, and that is very, very important. So now, plan B, and we have 5 more minutes. So let's say somebody has got an Osimertinib. How do you manage a patient on, let's say we have given Osimertinib first line. So I'll go to you, Pradeep. How do you manage a patient? Somebody has got a good systemic progression. Then what happens? Do you always biopsy?
No, sir, we are not
You don't
routinely
biopsy. So anybody who does a routine biopsy. Yes. So Nandini, what have you got till now?
MET amplifications.
How many times?
Maybe 15.
15% times. And do you act on that MET? You do act on that
We
MET.
have treated patients
Okay.
with tepotinib and
Do you biopsy routinely?
Routinely, sir.
Routinely. You get something out of it?
Yeah, I think.
Sure?
Not sure.
Okay. Because again, very important.
I have occasionally seen the transformation.
Yes,
And
transformation.
that is something that makes the decision.
So we need to, look at the plan B. Ashwin is going, and we hope and Rohit and Kohli goes soon. So, we need to look at the transition from plan B. The resistance pattern, I think I'm just going to change. The plan B options are here. But just again, for the residents over here, once you have a resistance, look at the three things. One, you look at the on target. One, you look at the off target. Third, as Dr. Sahu says, you look at the phenotypic. If you have not yet understood, just remember this. This is Shah Rukh Khan, since Dr. Sahu is going to go to Goa for the reunion. So, you can have an off-target mechanism. You already have somebody in Bhopal and you look at the reunion, that's an off-target mutation. You have somebody in Bhopal, the girl and the guy becomes better after reunion, that's an on-target mutation. The guy changes into somebody else, that's an absolutely phenotypic transformation. So you can have an on-target mechanism, you can have an off-target mechanism, you can have a resistance mechanism. That's not me, sir. That's a small cell transformation. That's the way it goes. So how do you, this is chemoimmunotherapy. So somebody with a PDL1 more than 80%, EGFR del 19 mutant, will you give a Pembro plus a Pem carbo? So post-progression, only IO plus chemo.
No, sir.
No, so that is absolutely there. I mean, even the little girl knows over here. So no, irrespective of your PDL1, please do not go ahead and give them any immunotherapy. Now, important thing is Mariposa 2. Pritesh, your take on Mariposa 2. Impressed with the results?
Yes, but I have not given yet.
You have not yet given because of the cost and because LAS is also not available. Again, very, very important is it's a good regimen. But three things you have to look for is, one is the infusion-related reaction. Please give the first drug in the ICU, at least we give this ICU setting. Make very good friends with the dermatologist. Third is give the DVT prophylaxis and DOAX over there. So ROI on this, I don't know how much will it get. Our favorite drug.
Can I ask something? How many of you have tried the 350 on day one and the
we
rest?
had to give in the trial, sir.
So how did you find the reactions are lesser?
Nothing. Same. If it happens with 350, it happens with 350. So
because the first dose usually is the highest, and
yes,
then
so we do 350 and the other one, and the first one goes to ICU and then we give, because in the trial we had a bad this thing.
So that is
but again, it's a grade 1, grade 2. But sir, somebody spending 5 lakh rupees and having a grade 1 also is a problem. I would like Akhil, 2 minutes. I'll just finish it off. I would like Manoj, our favorite whipping boy of medical oncology, atezolizumab and bevacizumab. Do you think there is a chance for an IO plus anti-angiogenic pathway in this? Are you impressed with this result? Not yet, really. Okay. Dr. Pradeep?
Yes, sir, there is conflicting data, so I think we should avoid giving in this situation.
We should avoid giving in this situation. Fantastic. Dr. Pritesh? ABCP regimen. That's what atezo, bev, pacli, carbo is what I'm talking about right now.
Generally don't give.
Generally don't give. Dr. Sahu?
It's alternative. You have a choice in the guidelines. You do it. If you have you have finished 1 or 2 lines, that's all of us go to that.
Okay.
But it's not it's out of choice they got this. It's a lottery for them.
Okay. I think I will show you this data in the end over there, but I think if there is a place for immunotherapy in EGFR-mutant non-small cell lung cancer, that is this. Atezo, bev plus a combination, and I think all these drugs have shown a good HR. If you look at this 0.6, 0.51, 0.62, the HR is good, and as usual with bev, you will never get an OS actually in that. So that's the issue. This is something which is very, very important for me. I'll go to you. Yeah. So you have given Osimertinib. If you get 100 WhatsApp questions, 90% people will ask, sir, should we continue Osimertinib with pemetrexed carboplatin? 2 more minutes. So do you continue in the real world practice?
No, sir.
You don't continue. Fantastic. Nandini? So somebody has got OC, and then you give on PD OC PEM carbo.
So we don't routinely do it, but I think it could be considered in certain.
It's the volume of progression is important, and that
volume, systematic progression, new liver mets.
If there are multiple new lesions, I don't think that makes sense to continue.
To continue over there. Okay. Actually, this is to me the most practical and doable things which can actually give you a 4.35 months of PFS. However, there have been retrospective studies which have already said this concept doesn't work. So please don't go ahead and look just because from Singapore and Tony Mock's hospital.
The point here is that if you give only chemo also, you would have got that 4-5.
Yes, 4-5 months over there. So we don't know. But the point is the only place where I use it if I really want to have a brain protection. So somebody has got some brain mets, asymptomatic, you don't want to really. So OC plus MEM is a good regimen for the brain. That's it, but it needs further trials. You just look at this. Actually, the maximum advantage that you are seeing is with a 4-drug combination of OC and Atezo, Bev, and this thing, which is there. So it is very, very confusing now, and trials are very, very important. So I will ask Nandini now. Nandini, on Monday morning, will you get a rebiopsy for most of the patients progressing on third TKI?
Yes.
Okay. Will you consider giving IO chemo in patients, only IO chemo, Pembro, Pemcarb?
No.
IO chemo, Bev?
In the past few patients, but after Empower 151, I'm not so convinced that we should offer all patients. Maybe.
Fantastic. Mariposa 2?
Yes, if
yes.
it is possible.
Consider for a clinical trial?
Definitely.
Yes. So I think this is what Evan said. I think, yes, Akhil, we will.
Mariposa 2 regimen versus Tropion trial, which is going to
which is going to come. So I think what we will do is, yes, for a biopsy, look for MET amplification. Again, very important is don't send the 12 gene coupon panel. It does not look for MET. We just now had a patient who had a HER2/neu. We had a patient who had a BRAF. So look for a broad-based panel in this. Please do not go ahead and give them single agent Pembro or Pembro-Pemcarbo, even if their PDL1 is 120%, which is not possible. Consider giving ABCB4 regimen. Yes, I will consider. Some data is there in that, also because I am going to speak on this session in the evening, so I can't be saying yes, no right now and yes in the evening. Mariposa 2, yes, but make good friends with your dermatologist. Will you consider for a clinical trial? Definitely, we will like to consider for that. And with this, thank you organizers for giving me the opportunity, and thank you for all the panelists.